We're going to go. Okay, so we are recording now. So Dr. Mario, I'm just going to let you get started. We're really, really looking forward to this. So.
Okay. Well, thank you, Lisa, and thank you to everybody for joining on this subject here. I'm a geek. I'm excited about this subject here. This is a big thing. This, in my view, is probably the biggest thing since ICD-10, and before that was HIPAA and all. So, and for those of you that maybe don't know me, I'm a chiropractor. I've been in practice 34 years up until April 1st, 2020, when I decided to go to Plan B. I sold my practice after 34 years, moved to Arizona, where today the high is 80 degrees, a new high, and out of the snow, and here to help all of you. And I teach for NCMIC, Foot Levelers, Chiro Health USA, and of course, now teaching for Gold Star today here. I'm certified in a lot of different things, most notably certified in compliance. I'm an instructor as well for this. It's a 100-hour course for Logan now, which is the certification as an insurance consultant. And I serve and have been serving for 11 years now on the Medicare Advisory Committee. By all means, obviously, Lisa and I have known each other for a long time, and she keeps you up to date. But another avenue, if you will, to keep everybody up to date is on my Facebook site. And this is not a sell job. I literally have thousands of people on there. I answer enough emails as it is, and so I just try to get the word out pertaining to all kind of subjects, including yesterday was Medicare. There was a few more changes with the fee schedule, but facebook.com/askmario. So all you gotta do is like me and then go into the notifications and just put me in your notifications so that when I post something, and I don't post junk, when I post something, it'll come up in your email, okay? All right, so we're going to talk about E&M guidelines here in 2021. And let me kind of set the stage. And, first of all, I am giving you, I call it the 36,000 foot overview of the guidelines. And obviously, we could tweak it and talk a little bit more. I think today it'll give you a pretty good idea. If you have my book, then follow along with the book. Not that I'm reading from the book, or I don't even read PowerPoint slides, but I did provide the notes for you here in today's class as well. But as far as clinical examples and more in-depth material, my book, which has been just flying off the shelves here. But if you go to askmario.com, if you use the promo code and for Gold Star attendees here today, use the promo code SAVE NOW, and you'll get free shipping plus discounted price. Okay, so let's just talk about E&M, evaluation and management. So, and I don't know where everyone is. I'm sure on the line we may have doctors, we have coders, we have insurance billers, and so forth. And for everybody, evaluation, which is basically how the doctor examines the patient and then managing their case along with that. And so when we look at it here, evaluation and management is considered to be the standard of care. And the standard of care is actually defined as the type and level of care an ordinary prudent healthcare professional with the same training and experience would provide under similar circumstances in the same community, which means when a doctor is sued for negligence or malpractice, you're always compared to what you should have done and what you did. And it doesn't matter what insurance it is. And that's the hardest thing for me to get through to doctors, is that the standard of care applies to all insurances, even if you just do cash. I don't do peer review. I teach peer reviewers, I teach them the standards, and I teach other doctors that as well. But I, on occasion, always representing the doctor, by the way, I'll go to court and testify as as an expert witness. I've already testified 3 times this year, and we're only in February, so it's been a busy year already. But the key is that even NCMIC can tell you that the cash patient is most apt to sue a chiropractor nowadays. So when we look back at the examination, and as doctors, we are trained to examine the patient. And in clinic, for those of you that are chiropractors on the line here today, I mean, think about it here. When we were in clinic, we did, looked in their ears, looked in their eyes, looked up their nasal pharynx, did all this stuff. And it's like, maybe if you do functional medicine, but rarely do we do that in typical practice in the chiropractic practice. But when you look back to the way the systems, different checks that we did, that those were considered the 1995 guidelines. Well, the 1995 guidelines, which took effect in 95, actually they came about in 1992. And so in 95, the guidelines came out, and everyone's going to use these guidelines now. Well, then the prima donnas, and I call them the prima donnas because that's what my medical patients, that work in the hospitals and all, they call them the prima donnas of medicine, are the cardiologists. And I can just imagine a cardiologist saying, "What? Do you know who I am? I am a heart doctor. I don't deal with the anus," and it's like, yes, I'm joking, but the key is they probably did say that. And so they go, okay. So then they came out with the 1997 guidelines, which were a tweak. And basically the 97 guidelines, and for us chiropractors, is how the nervous system, as an example, affects different organs, muscles, joints, and so forth of the body. And those are the 97 guidelines. I use the 97 guidelines in practice. Now, maybe you didn't know it, but doctors are supposed to declare what guidelines they use in their office. Nobody ever did. And, Medicare, CMS controls this, but so did the AMA. And they always said, well, we're going to come about and unify the 95 and 97 guidelines. And they tried to. Okay. And I've taken courses with the AMA, a 4-hour course on E&M. I took a 6-hour certification course with the AAPC just for evaluation and management. None of it was chiropractic. And, throughout all that, they said, we tried to get it together in 2014, we did beta testing. It still didn't work. Now we got it. Okay. Are they going to change it again? I don't see it. Okay. Everyone is saying, we finally got these. And so now play some taps or something, because 1995 and 97 guidelines are dead as of January 1st, 2021. Now, you don't need me to tell you that life has been turned upside down. Okay. I'm still very busy. All right. You are the first of 4 states I'm teaching in this week alone without leaving home. I'm teaching virtually. And, the way that we practice has been evolving, and COVID just kind of pushed it along. And so when you look at why did, some doctors will say, why did you change things anyway? I was just fine the way it was, but most doctors really didn't understand. And that's why the AMA and CMS said that they changed these guidelines in order to reduce the administrative burden of documentation and coding on the doctors and staff. And you might be snickering along and saying, yeah, right, but I think it does. You see, and because if everybody and all people now 95 and 97, as I said, the way you know it, those guidelines are gone. Okay. And so now we have a new system of guidelines, which really reflects more of what we do here. Because in the past, doctors would say, well, the chief complaint and the history of present illness, the HPI, has to be written by the doctor. Well, 2 years ago, Medicare changed it. And even if you don't do Medicare, you might say, well, I don't really do Medicare. I don't really care. Medicare is the largest of the insurance companies, and other insurances like United Healthcare, um, even Aetna, the VA, they all follow Medicare guidelines. And so Medicare, said, do it this way. And the AMA had their version, and now they've kind of got together here. Okay. If you're a medical doctor's office, there are coding for prolonged services in E&M guidelines, and Medicare and the AMA differ on that. But if, the most practitioners, and especially chiropractors, we're not going to be using a prolonged service because typically it's not medically necessary. And I'm using that term on purpose here. It's not medically necessary to be examining, being with a patient for over an hour. Now, you might give me exceptions, but this is an exception, not typical, not the rule here. So the bottom line is, when you look at anything you do, it's all got to be medically necessary. And that's really the overarching criterion that is necessary in coding. So it can go both ways here. You can do a level 2 exam, which is like a 99202 or 99212 for a problem that you diagnosed as a disc. And it's like, wait a second, a disc, this level 2 exam is kind of like self-limiting, straightforward medical decision making, no big deal. On the other hand, you could be doing a level 4 exam, and you'll see in the chiropractic office, even a level 4 exam is possible, but then you diagnose with cervicalgia and lumbalgia. It's like, give me a break here, okay? Cervicalgia is, neck pain, and I don't know why. It's my next door neighbor, pain in the neck, okay? So the key is it's got to make sense. That flow has to be there. And when it's not, they go, yeah, let's go ahead and ask for the notes. So you may be triggering an audit. And I'll talk more about that throughout this class here today. So the first thing, when you look at evaluation and management guidelines, is this a new patient or an established patient? A new patient is defined as someone obviously that you've never seen before or not in the last 3 years. Okay, so it doesn't matter on the type of insurance. Let's say before they were cash patient and now they're a PI. Oh, I did so much work. It doesn't matter. When did you last professionally see the patient? If it's 2 years, 11 months, and 20 days ago, it's still an established patient. Okay. Now, when you look at the bottom of the screen here, 99201. Now, I'll just give you a preview. 99201 has been deleted, but 201 to 205, the fourth digit is a 0. That tells you it's a new patient. A 99211 to 215, fourth digit is a 1. That tells you it's an established patient. The RVUs, which is like, the antique show, how much is this worth? How much is a code worth? That's the relative value units. And so the established patient E&M codes are worth about 20% more, or I'm sorry, 20% less when you combine like a 99202 to a 212. Okay, why? Because for an established patient, you don't have to, rehash their past medical history, their family history, and everything else. It's like, okay, the last time I saw you was a year ago. Have you had any new surgeries, any medication changes, whatever? Now, what about if you are in a group practice? Okay, well, first of all, if they are all the same type of specialty or profession, let's say everyone is a chiropractor, then has anyone in your group seen that patient in the last 3 years? Because it's all assumed to be the same level of knowing that patient. But if you're in a multidisciplinary practice, and I deal a lot with those, it's like, okay, if the MD or DO sees the patient and they refer them to the chiropractor as an example, now that chiropractor does an exam that to that patient, even though they're all in the same group, but the MD DO is a different specialty than the chiropractor. So it's still considered to be a new patient for the chiropractor. I devised this little flow chart here for you. And it basically says what I just said of arriving of whether this is a new patient or an established patient. Okay. So when we think back about the 1995 and 97 guidelines, as I said, those have been laid to rest here. There's a tombstone with it. But in the past, we used to use these components, if you will, the history exam and medical decision making. The history exam, medical decision making is what drove the code. Unless it's counseling, you rarely use time, you see. But because of the exam, like how many elements, how many bullet points did you have to meet in the exam and in your consultation, then doctors, especially with electronic health records, their notes are going from, like to 8 to 10 page report on the notes here, but it's easy just to click buttons. And we came about, they call it now, it's a cool term, I think it's cool, they call it note bloat, okay? Note bloat, which is basically garbage in is garbage out. I mean, you probably have seen these reports, it said like Cozen's test, positive right, and then explains how a Cozen's test is done. It's like, who cares? Nobody cares, okay? Get a book if you need to find out how it's done. But the bottom line is it positive or negative? And what side, and what does it indicate to you? Okay, so they did away with all that. It's kind of like, what, do a medically appropriate examination in history. Okay, so that's it's like, what are you presented with? What's your differential diagnosis? Do what's necessary. Okay. And so the second bullet, the amount of history, number of elements examined and documented, it no longer factors in. It's like, well, should I still document everything? Document what you did, document what you thought about it with medical decision making, but nobody's looking at that history and exam. Okay. So all that type of documentation is gone. Also, when we look at, what do we charge for? And yeah, you should charge for an exam. I don't care if their insurance covers it or not. We are not responsible for the insurance the patient bought. Okay. That's not our responsibility. All right. How do you go to Walmart, you put groceries on the conveyor belt, and, your bill is $75. How do you want to take care of that? They don't say, well, you don't, it doesn't cover eggs, so we'll give it to you for free. Dream on. Okay. It's not going to happen here. So the bottom line is, it's medical decision making or time that you spent on the day of the encounter, not the day before, not 2 days after. It's on the day of the encounter. Okay. And we'll go through that. But the key is now, you don't need me to tell you reimbursement's going down. Okay. What other business is there than medicine, where as the cost of overhead goes up, reimbursement's going down? But we have to be more efficient in our practices. And I talk to doctors literally, my plan B, part of it is consulting with doctors. And I do that. I talked to 2 of them already today. But, in consulting with doctors, I try to inform them how to practice more efficiently. Okay. And so, think about it here. We've gone through with COVID, we've gone through what I call a paradigm shift. Now, paradigm shift, I looked it up, and it's a fundamental change in approach or underlying assumptions. Isn't that it? Did we ever think last year when COVID, everything was coming up in the news. And remember, it'll be gone by, Easter. It'll be gone by Memorial Day. It'll be gone by Father's Day. And now here we are a year later, still living in this COVID season. Okay. We're used to saying the cold and flu season. And by the way, H1N1, have you heard of that flu? The Spanish flu of 1918, the mutations, that's what H1N1. Here it is 100 years later, 103 years later, it's still here. They haven't got rid of it, okay? And so along with the cold and flu season, we now have the COVID season as well. And so just as I have learned, looking out, I actually took this picture here in my backyard, is that a cactus, it grows flowers. And that's how it pollinates, the pollen is transferred here. It has adapted. And in life, we have to adapt, otherwise you die if you don't adapt. And so you need to embrace change, make the most of everything that comes your way. And I know this is an E&M coding class, coding and documentation, but, take into consideration how to run an office, all right? And I'm not here for practice management, believe me. But, keep in mind that, like in some offices, like if I go to my medical doctor's office, and not that they all have it together, but, they bring me back, they go through, what kind of problems I'm having, they go through my medication list, any new surgeries, anything else, they take my blood pressure, and then they say, okay, the doctor will be with you, shortly. So the key is that when the staff brings the patient back to the consultation or examination room, and they're asking those questions, that is the HPI. Now, tell me, what sense does it make for the doctor to go through all that all over again? You see, you don't need to. Now, you might want to follow up, because you and I know patients don't tell us the whole story, and they certainly don't fill out forms properly. I just had today a doctor from North Carolina said, we're updating our forms. Can you send us a packet of forms? It's like, get some therapy, okay? EHR will help you, a lot more here, okay? So the key is, and you may see a polling question come up there, so answer that polling question as I talk here. But the key is that your staff can do that. And I'm going to give you some macros as a suggestion. If you're working for a doctor or with doctors, then make a suggestion to them is ask them to, macros here, because one macro, if let's say Brittany brings a patient back and gets information, Brittany is known as the historian. So we'll have in our notes, historian, colon, and then it has Brittany's full name and credentials, if any. And then another macro, so historian, colon, and then the name of your staff who usually does this, okay? Then another macro would be the doctor. All the doctor has to do is say, I have reviewed the above information, and then the doctor has their name and credentials. You see, I have reviewed the above information, or if you want to put it in, the following information, whatever. Okay, so CMS, Blue Cross, I don't know of any insurance anymore that requires the physician to re-enter it. All the physician has to do is to document that they reviewed it. You see, and that's what we do in our office here. So the staff may, they when they bring the patient back for consultation, they can tell the doctor as far as what information is present, and then the doctor can bring it up after that. Okay, so that's just something to think about as well. Okay, so again, the extent and history of the physical exam is not an element. In other words, it doesn't really drive the code. Okay. Now, let me just tell you, and I always say our office, my office, but I'm still I'm the consultant for the office, but I'm the practice manager now too, and so I deal with that office every single day, and actually other offices as well. And so I will just tell you, like in our office, this is just to tell you, okay, our doctors in our office, they don't do consultation anymore. Yeah, they don't. Okay, you know why? Because we have a person who's trained. Okay, we have two medical assistants, and this is what they do. When a new patient calls, we'll set them up for two appointments. Okay, one is with the medical assistant to get some preliminary information from them, and the other one is with the doctor. Okay, so the preliminary information, technology, your phone. Okay, so here we make an appointment, and it's like Brittany will call you at 9 a.m. tomorrow to get some information from you. Okay, we email the forms to the patients. Brittany has a sheet, for consult, asks all the questions. The doctor then reviews it, and when the patient comes in the next day, number one, it eliminated no shows because they got some skin in the game. You see. Number two, the doctor comes in, introduces himself or herself, and says, "So I understand you've been having lower back pain that started 2 weeks ago when you were burying a body in the backyard." Okay, I'm just kidding. Okay. And then, and so you said you don't have any leg pain. Is that true? And no numbness in the leg. So it just shows the patient, number one, the doctor asks pertinent questions, but it shows the patient that the doctor knows about their case. And then the doctor examines them, you see? And then we do our report of findings the next day. The bottom line is that it cut down a new patient, filling out the forms in the office. You don't want them in the office filling out a bunch of forms, taking up your waiting room, right? All right. So the key is it cut down from 1 hour that the patient's in the office to about 20, 25 minutes, you see. And so, and the same work is still being done. And you know what patients have complained? Nobody, okay? Because people, they will stand in line for Starbucks, but they don't want to stand in line for a chiropractor, okay? So you just consider, using a telephone. You can do video if you want, and schedule that virtual consultation, get that preliminary information. Always follow up with COVID. I'm doing a class in several different states here on some of the neurologic sequela of COVID. One of my friends, he's 58 years old, been dealing with COVID for 7 months. He got AFib from COVID, had to go through an ablation of the heart. Okay, look it up on YouTube. Christopher Cross, sailing, that song there. You got Guillain-Barré from COVID. All right. So the key is you want to make sure, even if a patient had COVID, are they still unknowingly experiencing symptoms from COVID here? The bottom line is it's anything for medical decision making or time of what was done on that day. Okay. Now it's what the doctor did, not the staff. It's what the doctor did, not the staff, in time. All right. So you're not adding or padding the bill if your staff is asking questions here. The doctor has to be more efficient, you see, and see more people per day in order to make the same amount of money. And so staff, they can look at the chief complaint, the HPI, review of systems, and then what we call the PFSH, okay? The review of systems is still important. Doctors follow up with it because patients don't fill out those forms right, okay? There's no minimum review of systems, but here's an example. In your review of systems, there should be 3 classifications: denies, and then a colon, history of, colon, complains of. So denies, history of, complains. Okay. And so, here's some example, denies shortness of breath and chest pain, has a history of hypertension. Musculoskeletal. Why did I put the largest organ in the body in tegumentary? This is like with shingles, as an example. okay? The HPI, very simple. You know, we use LMN OPQRST nowadays. L is for location of their pains, okay? Modifying factors or mechanism of trauma, but modifying factors, numbness, and then of course the onset, provoking, prior interventions, the quality, which is it sharp or dull, radiation severity and time. Even in your SOAP note, when you're doing a SOAP note, remember SOAP, but the SOA is really, remember back, it's the history exam medical decision making. And the reason why I bring that up is the assessment is so important for medical decision making. Anytime an insurance company tells you that medical necessity of treatment was not shown, it's code for your assessment sucks, okay? So the assessment is basically the professional opinion of the doctor as to how the case is going on, okay? And so you're interpreting the data here. So I tell doctors for every region you're treating, answer these questions per region, okay? How is the patient improved in the neck if you're treating it, okay? Why do they still need care? You know, thoracic, lumbar, SI, whatever it might be. Patient is improved with decreased edema and decreased arm pain, but still has spasms and subluxation at C7. You see? Because your subjective plus your objective gives you your assessment. If I tell you that there's edema at C7, are you going to use heat or ice? Yeah, you're going to use ice. That yields your treatment plan. All right? So your assessment is really, that is the most important part of your SOAP note. Don't just give me the diagnosis 55 times. We already know what the diagnosis is. You told me that day one, okay? And patient is improved, how? I mean, why do they still need care if they're improving so much, okay? So the basis for the 2021 guidelines, get that first in your head, medical decision-making or time. Now, when you look at medical decision-making, there's 3 subheadings to medical decision-making. It's the number and complexity of the problems, which we'll discuss, the amount and or complexity of data that's reviewed and analyzed, and then the risk of complications and morbidity. Keep in mind that complications will slow down recovery. Comorbidity means that because of these other problems, they may have, there's a higher risk because the patient may die from the treatment or even the examination here, okay? So when you look at medical decision making here, you know, in the old days here, a level 1 exam, 99201, or for that matter, a 99211, a 99211 does not even require the presence of the physician. No doctor should be out there using a level 1 exam. And because the medical decision making for a level 1 exam is pretty straightforward, for a level 2 exam, it's pretty straightforward. The AMA said, you know what? It's not made for doctors, so we're just going to delete it. And sure enough, AMA and CMS have deleted 99201. Take it out of your computer. I've had more than one doctor say to me, you know, well, I'll just see what my software company does, you know, as far as updating documentation stuff in our EHR. You know, go get some help because it's not going to happen, okay? All right. I talk to software, you know, companies, and I won't mention their names there, but I said, you know, like as an example, April 5th, 2021, the Cures Act, not the CARES Act, it's called the Cures Act, mandated that patients have to have instant access electronically to their records, their medical records, okay? Now, before you ask me, you know, about that, we still don't know everything about it. But the software companies, when I ask them, what are they doing as far as a portal? You know, MDs have a portal all the time. They look at me and it's like chirp, chirp, right? Okay, so the key is if you wait for your software company to, you know, change their software, they're always reactive, they're not proactive. That's my opinion, okay? So
Mario?
Yes,
Hey, Mario, this is Lisa. Just real quick, I just wanted to just give the results of our
sure,
poll.
go ahead.
We have 73% of the pollers have said that they want to use medical decision making as their primary factor in the E&M code selection, and 27% said time. Then the question of, do you know how to appropriately document MDM under the 2021 guidelines? 73% said no, and 23% said yes. And then, do you know how to appropriately document time? 45% said yes, and 55% said no. So I just wanted to share those results of the poll, which tracks very well with why we're doing this class. So
Exactly, exactly. And kudos to you for having it, So the key is all that information you're going to get in the next hour. Okay. Now, you're going to be splashed with it, how deep it settles down into your brain, that's time will tell. Okay. But the key is, the notes are there. And so keep going over the notes. I highly recommend, and it's not to make a sale or whatever. I mean, I do this because I learned this material, I put it through the chiropractic filter, and then, I got 6 books now. Okay. So that's what I do. Okay. All right. So let's go on, but thank you, Lisa, for that here. Okay. All right. Let me just, okay, good. Now, sorry, I got to, there we go. Okay. Okay, so here's an example, just an example, okay? And whether you're thinking, should I use MDM or should I use time, okay? Let me explain it, and this will answer your question coming up right now, okay? Number one, and as an example, when you look at the definition of 99213, now don't get ahead of me here. You have it in your notes, just listen to me first, okay? It's an established patient. We can see that from the code, and it requires a medically appropriate history and examination. And listen to this, low level of medical decision making. Low level of medical decision making. Now, how many times per year do you charge a level 4 exam? Okay, well, a level 4 exam is a moderate level of medical decision making. Now, they're saying is that a level 3 exam for an established patient is going to take like 20 to 29 minutes. A level 4, 30 to 39 minutes. But, for those of you that have been in practice for a while, and I happen to think I'm a pretty darn good examiner. I do a very thorough exam, but hey, you know what? I'm efficient. I'm quick. I've got a scribe in the room, and that's moving things along. Okay. I used to see 60 some people a day myself. Okay. But the key is, why should an efficient doctor be penalized because you're efficient? In other words, if you do the same amount of work in 20 minutes, why are you going to charge a lower level of exam when, based on medical decision making, you did a level 4? Now, there are exceptions, and we'll talk about that, of when you may want to use time. But I will tell you, you know, when I have meetings, just like now, you can see my body language. And if I'm telling you, you can use time if you want, I'm kind of telling you, you can, but you're nuts. Okay. All right. And so just take that into account. So, keep in mind that documentation of history and physical exam still needs to be medically appropriate. History and the number of elements are not added into it doesn't determine the code here. And it's whatever you do, you, the doctor. And even in I'm on the carrier advisory committee, 2 hours, we spent face to face. I was the only chiropractor in the room, but every profession is represented. And, they said that, basically the day of the encounter, it's whatever you did that day. And they said that, if you wrote down that you reviewed a person's medical records and it took you 30 minutes, and they're thinking to themselves, 10 minutes should have done it, they're going to audit you. Okay, I'm just telling you. All right, and it's not just Medicare, Blue Cross, everyone else. Okay, they can't audit your brain, but you got to document what you did here. Okay, so again, the office or other outpatient, the history is still medically appropriate here, and it's what you did on the day of the encounter. Now we call it face-to-face as well as non-face-to-face, which means looking through a patient's past medical records, examining them. If they brought in an x-ray and asked you to look at it and you looked at it and all that, that goes into that medical decision making here. Okay. Now, there's always like labor unions, some labor unions, this third bullet here, how are they going to take on the new E&M coding? A year from now, I'd be happy to come back, because now, it's not the guidelines, but it's how the guidelines are applied for each insurance company. Now, I can tell you what Medicare is thinking, because I've been in meeting with NGS, with WPS, and with Noridian. Okay, I've already been to meetings with them and classes there, and I could tell you that medical decision making is most probably, and I'm not telling you what to do, but I'm just telling you, practitioner to doctor to doctor here, it'll probably be MDM. Okay, now again, non-face-to-face time would be, if you're looking at patient records or whatever, and the patient's not there yet. And that's why policy is to, if you don't own an x-ray machine, get those radiology reports before you do a consultation. I had one doctor say, how can I get it before the patient? Have the patient request it to be sent to you. The patient has control of the records, okay? Make the patient be an advocate. We don't have to do everything. We don't have to spoon feed them, all right? You just, in that initial consultation, pre-screening on the telephone, tell your staff, to call the hospital, get the images, the reports. I like to get the disc for static images, because, they don't properly read for biomechanical alterations. Okay, so it's non-face-to-face as well as face-to-face time is added in. Okay, all right, now let's just walk a little deeper into the water here. I know we're getting used to the cold water, but let's talk about medical decision making. Okay, so first of all, it's time or medical decision making. If you're not using time, then you're going to use medical decision making, and vice versa. Okay, so what is medical decision making? It's defined as the process of establishing a diagnosis, assessing the status of a condition, or selecting a management option. Okay, so the table for MDM, medical decision making, has not changed. It's still a level 2 exam is straightforward, low for a level 3, moderate, and then high. Okay, so most chiropractors, we're not going to do a level 5 exam, and we're definitely not going to do a level 1. Okay, just take that out of your head here. Okay, so and I won't even get into it, but I'm going to touch upon it. I had one doctor, he literally starts screaming on the phone. Okay, and this is a client of mine. He goes, why do I have to charge a Medicare patient for an exam if I don't want to? Because it's considered to be an inducement, a violation of the anti-kickback statute. Okay, if you do a service, well, then I just won't do it. Well, then you're going to get sued and lose everything you got. Okay, all right. The bottom line is, do a good job, charge for what you do, and bill it properly. And you know what? Patients don't complain. Okay, and if they do, it's because they've been to someone else down the street who's giving away the farm as well. Okay, so keep in mind that everything has to be medically appropriate, medical necessity, but the diagnosis does not have to equal the level of exam. And here's an example, okay? And I have it in the slide. You can read the slide, but listen to me better, okay? If I took in a bunch of the patient's symptoms and signs, and it's kind of like, okay, doc, what could this be? Well, it could be cauda equina, not common. It could be a disc, could be sciatica, it could be it could be prostatitis. That double leg sciatica is prostatitis. Okay, so based on your differential diagnosis, you may have to do like a 99204 or 214 examination. But then it turns out your diagnosis is not that heavy duty and definitely not a cervicalgia or lumbalgia, but it might be sciatica. You see, the bottom line is that the problems that they spell out, the doctor takes it into account and says, "Oh man, this could be a problem." Okay, all right. Let's just I'm going to give you an example here. Okay, look at this over here. The patient presents with lower back pain, but because of a history of uncontrolled diabetes and heart disease, the risk is increased and will affect the rehabilitation that's prescribed by the doctor. Okay, and so here you're looking at a risk to benefit analysis because you're not going to take a patient with COPD and heart disease and diabetes and have them run on a treadmill. Okay, I'm kidding, but you know what I mean. The second bullet here, the provider documents that the comorbidity factors are considered because it adds to the complexity. Now, if you do rehab in your office, would you do rehab on a patient who has uncontrolled diabetes and heart disease? Now, I'll bet, if we did a poll, maybe 50% of you will say, yeah, but I'm going to modify it. See, the modification, that's medical decision making. That's using your brain. Are you paid to think? Yes. That's the new guidelines here, is they're paying you to think, finally. So when you look here, compare 2020 to 2021, here it was the number and diagnoses of management options. Here it's the number and complexity of the problem. You see, it's not the diagnosis per se, but it's like the complexity of the problems, the amount and complexity of the data to be reviewed. But now, for all of those who always ask me, what about if a patient brings an x-ray or the disc nowadays, into the office and said, I had these done at, St. Mario's Hospital. Will you take a look at them? Well, I'm not going to reread them. Let the radiologist take the bullet, for pathology, but I'm going to look at it for biomechanical alteration. And there it is, amount and complexity of the data to be reviewed and analyzed. You see? Yeah. And then the risk of complications and or morbidity or mortality of patient management. So it's tweaked it a little bit with MDM, but made that a primary factor. Okay. So again, when we look at the three subheadings or three elements of medical decision making, here they are right here, highlight it in your notes, put an asterisk there, because that's what's going to determine it. Number one is the number and complexity of the problems. I'm going to explain all this more. Okay. Number two is the amount and complexity of data to be reviewed and analyzed. And number three is the risk that you considered, complications, morbidity, complicating factors at the time of the visit here. Okay. And so it's the number and complexity of the problems. And we talk about problems all the time. A problem is one that is addressed or managed if it's evaluated or treated at the encounter. Okay. In other words, what was decided and done that day must be documented. Okay. All right. Documentation has made my career. Documentation bought my house because that's what I teach doctors. If we did a risk, management, asset protection, documentation will protect your assets. Okay. So the key is document what you did here. Document consideration of further testing. If the patient's not doing better in 2 weeks, we're going to send them for MRI. Okay, as an example. Treatment options. If the patient is not improved in 2 weeks, we're going to send them for a consult with the neurosurgeon or to the pain center. All right, the referrals. testing and treatment that were not chosen, even because, maybe you presented to the patient and said, well, I recommend that you haven't really been improving, and we could consider sending you to a neurosurgeon. And the patient says, I don't care what you do, I'm not having surgery. You see? And so you write that down because the patient still has control over their body, believe it or not. And, it could be a person with dementia might be an authorized representative, a guardian, or a parent for a child, or somebody disabled here. Okay. So it's basically any information that you have obtained from multiple sources. Okay. It could be even what we call a historian. It could be your staff, but it could also be like the spouse. I mean, the patient comes in, it's a guy, and he goes, my back hurts, and his wife's with him, significant other, and she says, well, let me tell you how it really is. Okay, he can hardly get up out of bed in the morning, and he's been sleeping for 6 months in a recliner. Okay. So there, the patient doesn't have to say, oh, she's right, because she's always right. Okay. The patient, you can just write down, the independent historian is the patient. Okay. Now, I threw in some examples here. I'm not here to push a foot leveler's kiosk, but I use that in my practice too. But I just want to give you some examples of medical decision making and stuff within your office, even if you don't own an x-ray machine. It's interpretation of tests that are not separately reported, which means you don't have, as an example, a CPT code for doing a kiosk. If you run a scan on a patient of their feet, how do you charge for that? That's part of your exam. It is, okay? And so that's why, scanning those patients will give you more information. So, the guidelines, clarified test, independent interpretation, independent historian, and risk here. A test is like each unique test or order that is documented, that that you documented. Basically, if you looked at an MRI, okay, here's an example. You look at an x-rays of the cervical spine, thoracic spine, and lumbar spine that were done at the hospital. That is not one test, it's 3 separate tests: cervical, thoracic, lumbar, you see? So here, it's not you're not looking at how many different tests, but the complexity of the data, because like in a PI case, here you have a lot more information to look at, such as, did you get the accident report? Did you get the medical records from the ER? Did you get the patient, by the time they come to us, they've got what I call baggage here, okay? And then independent interpretation of the test would be if you looked, because, as an example, if there's a hyperplastic transverse process, a scoliosis, a cervical kyphosis, it's not even recognized on the radiology report, but then you put it, that the biomechanical alterations here. And then when you discuss it with any other doctor, and, those of you, like in my profession, doctors call me up, and, people I know, and they go, Mario, you got a minute? I just had one yesterday. Okay. Do you got a minute? I've got a patient, this patient presents with this here. What do you think? What should, what do you advise? Okay. Well, I still, even though I'm retired, not really, but, plan B, I still have an active license in Illinois. I'm still a physician. And so you document that you consulted with, there it is, a qualified healthcare provider. Okay. So, that I would say, when you're looking at options for care, and you look and you talk to your gold star representative here, that could go into the management or test as well. Okay. All right. Independent interpretation. Again, as long as you're not charging a CPT code for it. Okay. Now here's some macros. Doctors always ask about macros. Here's some that you might want to add in to help you with your documentation. Don't do it because it's going to be there every time. It's kind of like, let it give you a little nudge. Okay. It's like, did you do this? I reviewed the x-rays of the cervical spine taken at St. Mario's Hospital on March 25th, 2020. Okay. The one I like, I independently review the x-rays taken from an outside facility, St. Mario's Hospital, and brought in by the patient. And then you give your comments. Okay. Now that's a lot to write, but those of you that have electronic health records, 74% of you here, but if you don't, then talk to the other 74%. They can tell you why it saves you time, tremendous amount of time here. Okay. All right. So when you look at the number and complexity of the problems, a straightforward problem is pretty self-limited. Okay. A low or stable condition here, that would be a single problem. I mean, how many times do you treat a patient who has cervical and lumbar problems? Well, here, that might be even a level 4. I'm not saying to charge level 4 on everybody. I'm just telling you, you probably want to look to see, those problems that are multiple problems or significantly ill. I think if they have a hot disc, that would be considered, significantly ill. So here's tables, but, just look at this here. Okay, the 3 elements I gave you. So just look over here first. I gave you 3 elements of medical decision making: number and complexity of the problems, the amount and complexity of the data to be reviewed, and the risk. Okay, out of those 3, you need 2 out of the 3 elements must be met to determine the code. It's kind of like, what is the lowest common denominator? Okay, so as an example, a level 2 exam. I mean, a level 2 exam, some doctors, that's like their mainstay, but a level 2 exam is like one self-limited or minor problem. That is made like, and it's not the complaint that gives you the code. It's like the differential diagnosis. Okay, the patient says, I don't know, I must have slept wrong, and I got my vaccine and I'm going to go on a trip to Hawaii now. Okay, and go golfing. So, and I just want to get, adjusted before I leave. All right. So that might be a level 2 exam as an example. When you're looking at, a level 3 exam, low, so it's a low complexity, which could be a stable chronic illness here, and, a stable chronic illness is like degenerative disc disease. It's there till death do us part, right? Okay. A stable patient is, is considered to be at MMI. All right. An acute, uncomplicated illness or injury could be maybe a sprain. Remember, sprain supports the manipulation, strain supports soft tissue work. So you always include both. Okay. All right. All right. Here's a level 4. Okay. So a level 4, one or more chronic illnesses. Just to ask yourself, do you ever see this? One or more chronic illnesses with an exacerbation or side effects. Side effects, muscle atrophy. Or 2 or more stable chronic illnesses, or an undiagnosed new problem, or an acute illness with systemic symptoms. Systemic would be like now they're having bowel and bladder function problems. Okay. Do you ever have a patient with sciatica that has constipation, has menstrual changes? Okay, there you go. All right. So, those kind of things there. And again, we're looking at 2 out of 3. Even for a level 4 exam here, moderate, you have categories here. It's any combination of the 3, reviewing the external records here, review, each unique test, ordering, assessing, independent interpretation, and then, talking with somebody. All right. For moderate, it could be, we don't use prescription drugs, but it could be nutritional supplementation, things like that. So it's 2 out of the 3. When you're looking at risk, it's the complications, morbidity, and mortality. Okay. In other words, it's like this, what have you discussed, like the treatment options and what are the risks? Okay. We deal with risk every time. It's just you don't think about it. It's like, oh, I didn't think about, that I actually am breathing. Yeah, well, we do it all the time. But the key is, it's like, if you're going to order an MRI on a patient and they're claustrophobic, are you still going to order that MRI? Oh, how about an open MRI? You see, that's medical decision making. We do it every day. It's just you don't think about it. You don't think about what you think. Okay, I just made that up. Okay, so anyway, the assessment of the level of risk is affected by the nature of the presenting problem, the history of the presenting illness here. Okay, and so it's not that you find out, oh, it's not what I thought it might be, but it could be. You see, you got to rule out and rule in. All right. And so that's why when you look at medical decision making, it's like, what did you order? What did you not order here? And the last bullet here, medical necessity of the service will still need to be evident in the documentation. Why did you do an exam? Why did you even do an evaluation? Okay. What's the rationale? Well, don't give me the rule out. You never put rule out. When you're putting rationale, always give clinical indications. Okay. All right. And we'll talk a little bit more about that. So just hang with me. Okay. So, again, amount and complexity of the data to be reviewed and analyzed here. 2 documents or an historian, independent historian is a level 3 exam. Okay. How often do you do that? Yeah, we do it. How about 3 documents, independent historian, interpreting documents, or conferring with another provider? Okay, I had a patient referred to me for headaches by an oncologist, and she has bone cancer. I'm thinking, what the heck, And so then as far as bone cancer is concerned, it's like possibly, could I treat her or not? And so I talked to the oncologist, looked at the PET scan, got all the records there. Believe me, that's a level 4. I did treat her. I'm thinking, oh, what a way to go, right? I adjusted her. She started crying. It's a true story. She started bawling. I mean, crocodile tears. I said, oh my gosh, and I said, just remember, my name is Lisa. Okay, Majewski West. No, I'm just kidding. But, and I said, what's the matter, Stephanie? She goes, this is the first time I haven't had headaches in 8 months. That's what we do. But it's kind of like, I call it pucker factor. That's medical decision making. Okay. All right. Hopefully you appreciate my sense of humor. Okay. So again, tests, each unique test, what did you order? What did you review the external records here? And then discussion with the family, the patient. It's not counseling, but kind of counseling, or with another provider. I mean, doctors call each other up all the time, hey, John, sorry to bother you, but I got this patient, has post-concussion syndrome, I believe, has these symptoms here, had a fall off of their bike. Is this something you would see? What do you recommend? Medical doctors do that all the time. Chiropractors were like little isolated islands. Okay. So, documentation, when you assess a problem, it's anything that's obtained, from multiple sources, interpretation, as I said, as well, those kind of things. So remember this table that I gave you, and, 2 or 3 elements here. So we talked about the number of problems. Okay. By the way, like in my E&M book, okay, the E&M book, I actually have checklists. Here's the book right here. And so, towards the back, if you have the book already and you're following along, you'll see where I call them audit inventory tools. And there's like checklists here. And basically, did you do it or not? You see, and this is where it comes from. Okay, I'm referring to page 64 as an example of my book there. Okay, and so amount and complexity of the data to be reviewed. And again, looking at the different categories. So keep in mind, like you have category 1, which is like review of prior external notes there. Did you do it or not? If you did, how many different things did you look at? Review results of each unique test, ordering of the test, assessment. And then you see, so, even like x-rays, if you do it in your office, lab work, if you do it in your office, even that foot leveler scanner, make it work for you, make some money for you, okay? All right. If you need to, go to footlevelers.com/webinars, and I've got even archived some classes I've done for them, okay? All right. So it's those categories there, okay? Or it's a combination of them. Category 2 would be like independent interpretation of tests, okay? And as long as there's no CPT code that you charge, okay? Or category 3 would be like discussion of management of the test, interpretation, not necessarily with the patient, but with a qualified healthcare professional. By the way, in case you're wondering, what is a qualified healthcare professional? It's someone in like not in your group or in a different subspecialty. It's not the family. It's like anybody, Medicare said it's anyone with a, not in your group with an NPI number, just to give you an idea, okay? All right, I know maybe your head's buzzing a little bit. That's okay. I understand. That's why I gave you the notes. The book even explains it even deeper, okay? And so again, when we're looking at the amount of complexity of the data here, this is the kind of stuff you're looking at, okay? So how many problems are you addressing? Taking into account the amount and complexity of the data, and then the risks, of course, okay? So even a level 2 exam is minimal risk. You're not going to kill them. It's like no big deal. The older the patient gets, or some people have a lot of baggage, I call it there. And so now you might be dealing with a higher level of risk as well, okay? So when we look at the level of risk here, again, determined by the number of diagnoses that you're managing, or actually, even though you're not managing their diabetes, maybe you're still taking into account. All right. Keep in mind, a complicating factor is diagnosed as anything that will slow down the recovery of a patient. Tests, okay, lab, possibly x-rays. I would say even a scan, the kiosk scan here. Low physiologic tests would be like a physical capacity evaluation for rehabilitation in the office. All right. Lab, of course, there, management options here, bed rest we don't do, but are you putting them on limitation of ADL, activity limitation, work restrictions? Okay. This is stuff we do. You document it. That goes into, your management options. All right. Elastic bandages, dressing, no, but how about K-tape? How about a lumbosacral support for DME? You see, here it is, over-the-counter nutritional supplementation. Anti-inflammatories, omega-3, bromelain, papain, which are proteolytic enzymes here. Okay, physical therapy. Even if you're doing it in-house, but you order it, the doctor orders it and doesn't necessarily have to do it, all right? Things like that. A moderate level 4, again, 1 or more chronic illnesses, 2 or more stable chronic illnesses here. It's not just me, but the American Academy of Professional Coders said most doctors undercode their E&M codes. So again, if you're putting a level 2 there, that might be like a little kid who's like a no-brainer. But consider these things here again. Diagnosis procedures and management options here. Okay. So here's an example, just that I did on a prior webinar, but I threw it in for you guys here. The patient has lumbar pain. They have right SI pain. They do have hyperpronation syndrome, flat feet, that are affecting their Q angle. And you have, objective analysis through the kiosk showing the kinetic chain disruption. They also have a history, and you have verified it, with radiology reports of lumbar DDD. Okay, so here is 2 or more self-limiting problems, lumbar and SI pain, a chronic illness, okay, which could be the lumbar DDD and maybe even hyperpronation syndrome. So right off the bat, that's a level 3 exam. So when you look at, like the red flags of pronation, you learned about that, but different things we do, that's all your rationale of why you're getting or ordering certain tests or even evaluation on a patient here. Okay, all right. So again, hopefully you're starting to get some thoughts of it there. Okay, I already talked to you about x-rays. Now, throwing in like that kiosk scan as an example. Okay, so amount and complexity of data to be reviewed and analyzed. Well, if you have that scan, by the way, and you're looking at the pronation index, and I analyze it, I cut this in half, tell the patient, this is how your weight bearing, it's like a 3-legged stool. This is how the weight bearing should be on your foot. Look at here, you have a total collapse of the arch. All right. Your pronation index 0 to 34 is normal. Yours is 3 times worse. Okay. And then here, your weight bearing is more on the right side here. That is all the data to be reviewed and analyzed. How many of you have done this before, but you don't document it? You want to document, you see? All right. So this is where, the diagnostic procedures, ordered, you ordered a scan, and then the management options, are you going to order, whatever else? I mean, DME, including orthotics, whatever, that would be your management options, selected there. And, again, physical therapy, rehab, whatever you do. And so, again, just with my clinical example I'm giving you, like orthotics, foot orthotics, I don't care what company you use. I do. I mean, I use Foot Lovers. I know what they do, but, it's like, what type of Foot Lovers are you going to order? Are you going to order for dress shoes as well as athletic shoes? That is medical decision making. Okay, what type of top are you going to use on that, or custom made flip flops if they're always in flip flops? This all goes to medical decision making. Okay, it's your ordering rationale here. Okay, so just some of the documentation I talked about. Your examination findings. What did you order? Kiosk scan. You could put radiology. I still take x-rays of my patients as appropriate. Independent interpretation of the test. Then, what type of orthotics, and, they can use the Take 2 promo code, and then the options there as well for treatment. Okay. And so the bottom line is, here, complicating factors to be considered. That's a great macro. Oops, come back here. Sorry. Okay, that's a great macro right there. Okay, and then you want to document everything, even stuff you didn't do. Okay, it's your thought process. That's medical decision making. Now, if a patient comes in, just work with me here. Okay, a patient comes in and they are limping and they are literally urinating down their leg, cauda equina. And I look at that and it's like, oh my, okay. So now we're going to send them frank referral to the ER, okay? How long did it take me to do? 10 seconds, 30 seconds, even if I'm slow thinking, 1 minute, okay? But the level of medical decision making, because of my experience and practice and my knowledge, was high, you see? And that's why time doesn't always work. All right. And so when you're looking at things here for the level of medical decision making, in my opinion, this is just my opinion, I think MDM will go a lot further. But, always, why did you do an exam? Why did you do x-ray? Why lab work? Maybe you want to look at the ESR. Maybe, a patient has history of rheumatoid arthritis and you want to see if they have rheumatoid factor. So always have, along with the test that you order, always have like a macro in there asking you, rationale, kind of giving you a nudge, like give me the rationale. Okay. Now, there's something new to E&M. And you and I, we say that we don't treat the patient's pocketbook. Okay. But let's be honest with each other. If you say patients need this, and they go, my insurance doesn't cover it. I mean, why is it a Medicare patient, Medicare requires an exam, but they don't pay for it? Why? Does that make sense? No, it's the government. What do you expect? Okay. Or a person who's deep in poverty has Medicaid, and like in Illinois, as an example, some states, Medicaid doesn't cover chiropractic. And so, or, what hours do you work? I work from 9 to 6. Well, that's our office hours. Okay. Well, that's going to be a problem getting in, isn't it? Okay. Yeah, you work an hour away, so you can't really come away. So all those factors, complicating factors, if you will, those are what we call, they're social factors. They're called social determinants of health. And there's different types of social determinants of health. SDOH is how it's abbreviated, availability of food. Okay. Why do you care about availability of food? Well, when you're doing nutritional counseling with them, the poorest eat the worst, right? They fast food, high fat, salt, and everything else, right? Housing, poverty level, their mental health. With COVID, we have depression, vitamin D deficiency because everyone's working from home. Yeah. I was talking to a medical doctor in Philadelphia. He said he runs vitamin D testing on all of his patients. 90% of them are D3 deficient. So 5,000 international units of D3 for your patients. The ICD-10 codes are those Z55 to Z65. There's a whole new level of coding. And here's all the different categories. I mean, even like gender inequality. I just did a class last week for Oregon on, LGBTQT community. They are faced with decreased levels of health. All right. Just to give you some of the examples here, like extreme poverty. Okay. How about unemployment or change of job, threat of job loss? Oh, you're going to go see a chiropractor. If you're seeing a chiropractor, we're not going to have you work here. Have you ever heard that? I have, things like that. Or, neighborhood would be, like, here's a good one here: dietary counseling and surveillance, exercise counseling, tobacco use. Okay, there's so many different codes. I did, and again, just to let you know where the resources are, I have my ICD-10 coding book, which is all updated, and it's only a few weeks old here, but again, that's available on my website. It gives you everything there, including all these codes. Okay, if you do rehab, what are the best codes to use with rehab and everything else? Okay, all right, and I'll show you some promo codes at the end here. Okay, all right, let's start to talk about time and wrap this up here. So time, it's the total time on the date of the encounter, and here it is, folks. Documentation of time must be exact. Okay, do you have to itemize time? Yes, that's all the indications I'm getting. Who told you that? Well, the AMA and Medicare so far. All right, so I mean, who else is there? Okay, all right, so is the time personally spent by the physician and the staff on the day of the encounter, and staff, as long as they're a qualified health professional, like if you have another doctor, an associate doctor in the office. But are both doctors going to be working on the patient at the same time? You can't double dip. You can't charge for this doctor's time and this doctor's time if they're in the room on the same patient, okay? But that's why, although it doesn't include the clerical staff, when the doctor refers to that information obtained by the clerical and clinical staff, now that goes to MDM. You see, it makes life easy, okay? So, define, like, what is the total time, spent on the patient, reviewing tests. You can do it like I said, I have checklists here, did you do this or not? But think about it this way here, folks. Did you do this or not? Not the time that you took. And you could have a stopwatch if you really want, okay? I personally am not going to be walking around with a stopwatch timing myself. How long is that going to last? And then pretty soon you're going to say, well, I spent like about 30 minutes. But here, this is a nice checklist for you to use. And, this continues it here. Now, documenting in the health record. Okay, in the last meeting I had with Medicare, which was about 2 weeks ago, and they talked about this, and, a doctor asked, are you going to really pay us for time of putting the notes in our computer? And the person who he asked that to is the head. She's the head of she's a risk management nurse for Medicare. And she looked, and just her body, she goes, I doubt it. Okay. I mean, that was just the way she came along here. Okay. But again, independently interpreting tests and so forth. Now, if you're going to add time up, again, for a level 1 exam, that time is not a factor. Its time has been removed. But level 2, a new patient, it's in 15-minute, little classifications here, 15 to 29, 30 to 44, and so forth. Okay, for an established patient, it's 10 minutes, 10 to 19. Now, it's not like if you did 19 minutes, is that considered almost like a level 3? Yes, but they expect an itemized statement of time, and 19 minutes is still a level 2. So I'll talk a little slower. Is that medically necessary? Probably not. So it's the pre-service, service, and post-service time. And of course, this is for occupational services, as long as there is not a CPT code associated with it. Because that CPT code has a global fee, which is a technical component and professional component. Okay, all right. So again, some of these activities, they don't need to be performed face to face, but on the same day of the service, of course. Counseling and educating could be with the family, the patient, caregiver as well. All right. Ordering medication, further testing here, referring and communicating with other healthcare professionals, documenting the clinical information here. And again, it all indications are it might be subject to audit. Okay. Time to interpret and communicate the findings here. And of course, care coordination is, talking to other providers as well. So if you want, you can start to time yourself now, folks. We're in the guidelines if you really want to, but again, documentation, this didn't come from me. This is from classes I've taken here. Documentation must clearly indicate the nature of services performed. I spent an hour on the phone after the patient's appointment is not sufficient in documentation. What did you talk about? Who did you talk to? How long did it take? Okay. And so, that documentation of time here, and again, for those prolonged codes, even a level 5 exam is, over 50 minutes for an established patient, over an hour, typically not in a chiropractic office. So how is the time to be documented? We'll find out more so, but I will tell you, all indications are it's going to have to be itemized, and it may be an issue here as well. Okay, so let me tie it in, and then I'll take questions. I'm okay on time if you are, so, and I know everybody's got things to do, but number one, what problems or conditions are you managing? Consider that. Not even the problems, although that is part of it, but also the number of problems. Okay, what's the complexity of those conditions? Document a clear assessment, because that's your medical decision making and your treatment options, your treatment plan. Okay, remember, a treatment plan always has to include objective measures to evaluate treatment effectiveness. Everyone has adopted it. Objective measures, which is not pain. It'd be like active range of motion. Okay, so give me the degree. Outcome assessment tests. Your mandate is improved function. You got to do it, period. Okay, outcome assessment tests. All right, maybe muscle strength testing, whatever. Indicate the tests that are being ordered, that you interpreted here, and document here. Okay, so keep in mind, you might, what I taught you here and what you're doing now, I imagine there's a gap. Some is like the Grand Canyon, okay? Some it's like, okay, I can jump over that. So you do a gap analysis here. Where should you be? We are already in 2021. There's, what's the grace period? You already went through it, okay? It's done, okay? You got to do it starting now. Review the guidelines, fill in the gaps here, and make sure your EHR software is prepared to update. But I gave you some macros, okay? In my books, both the E&M and the ICD-10 coding books, I give you macros as well, okay? Monitor, CMS, your MAC, which is like your carrier in your state for Medicare, the AMA as well, different commercial carriers here, and make sure you take classes. Just because you took a class now doesn't mean a year from now we're not going to be tweaking it, because I'm sure it will be. And as the tweaks occur, facebook.com/askmario, just like me here, okay? I gave you a lot of resources, that you can look up here. Again, there is a combo price if you wish to buy the book here, both the ICD-10 and if you go to Ask Mario, there's a combo, book combo, which is a special rate. And if you use the promo code SAVE NOW, put it all in capital letters on checkout, it will save you some money, free shipping here. And we ship out every day, our store does. And so my workers, I compensate them well, which is my wife. Okay, so anyway, it's cheaper than a lawyer. Okay, so Lisa, I'm going to turn it back to you. But folks, before I leave you here with any questions you might have, here's information again. NCMIC.com, footlevelers.com. Here's my website, askmario.com. My email is doc@askmario.com. In the subject line, if you send me an email, just let me know you were in on this call today so I know it's you, okay? All right, Lisa, back to you.
Mario. That was so awesome.
Thank you.
First of all, I just want to let you know that in the chat box on the Zoom menu, I have the information also on purchasing Dr. Mario's books. There's a direct link to his website, so feel free to use that link to get over to the website to purchase his book. I've also asked folks to type in their questions in the chat box so that we can have a bit of a Q&A. And so I will, if you do have any questions, and you wouldn't mind just typing your question into the chat box so we can go through them pretty quickly. We do have a few questions, Dr. Mario. So number one, we've got one that's from CE that says, he said that clinical staff could do history exam on one day and the doc have visit on a separate day, is the work the clinical staff did billable? If so, what would that code be?
Okay. Under no circumstances, Doc, under no circumstances is the clinical time that the staff took, your CA, if you will, under no circumstances is that time billable for them, period. Okay. And that's why in my, I'm helping to manage 8 different clinics now. And in my field testing, medical decision making works best. It's on the day. And doctor, what you do is you document that you reviewed it. The more information, the more complex it is, the higher the code, but it doesn't necessarily have to take more time. So you can't bill for your staff time, but it's to save you time. It's making you money.
There is one code which is under the telemedicine codes, the virtual check-in, that can be billed for. And if you all have questions about that, about doing your check-ins virtually, feel free to reach out to me and I can help you out with that. With what would be appropriate for a virtual check-in. That can be done by clinical staff, but that is the only instance in which there could be a bill for it, and it's a very, very low reimbursement. You're not going to get a lot, but if it's something that you want to explore, you could certainly do that. And it's especially helpful if you have a patient portal.
Now I will tell you, Lisa, too, that in my experience, check with your board of examiners. Not every state approves that. Right. And number 2, check with your malpractice insurance carrier, because you got to have documentation of the hub site and the spoke site. And if you don't know what those are, then you have no business billing for telemedicine.
Right.
Okay?
Exactly.
Yeah, be careful.
But there is that option. It's just, you have to have, it's very specific criteria. So let me know if you want information on that. The next question that came in was, is there a download printable version of this PowerPoint?
I sent it to you, Lisa.
Okay.
In the notes.
Okay, very good. Then I will get that out to everybody who registered. And also we recorded this. So if you want to go back, I'll be converting the recording and putting it on the website. So you'll be able to listen to this again at will. Let's see, that I also, just FYI for all of you, because I get this question a lot, is how much do you charge for these exams? We cannot tell you what to charge. However, I did post the national rates, the national Medicare rates for exams. This is what Medicare pays nationally. And of course, the different localities are going to have different rates. And so you can look at least what Medicare is paying for them. And all I'm going to say is, if you're lower than that, you shouldn't be. Okay. And so, for example, a 99212 is being paid on a national rate at almost $57. And I'm still seeing doctors charging $25 for a 99202, so.
But keep it,
Go ahead,
I'm
Mario.
sorry.
No,
Okay,
no,
I was
go
just
ahead.
going to say, keep in mind, okay, number 1, if you're in any PPO, I always have my doctors at the beginning of the year. Now, Blue Cross many times will even update their fee schedule in June. But if you're in a PPO, you are privy to that fee schedule. When was the last time you call customer service up and say, please send me a copy of your current fee schedule, and look to see, like, what are they reimbursing, whatever. Okay. And Medicare, even though you say, well, Medicare doesn't pay for an exam, it's still there. And I have one doctor, he works in a rural area, and he ties his fees in with Medicare. Okay. So do your due diligence. When was the last time any of you got a raise? Okay. You got to look to see what the reimbursement rates are.
Well, and I would also say that, and Mario, I'm sure you're aware of this, but I would say, in looking at our attendees, we've got probably about 60% of our attendees are multi-specialty practices. where they've got nurse practitioners or NDs or DOs doing these exams, which are
Yeah.
covered by Medicare. So, we're still seeing rates that are lower than the Medicare allowable, which is an inducement. You're not allowed to have your cash rates, or your rates lower than the Medicare allowables. So make sure you understand what the value of these codes are. And then the next thing is a question to clarify. This is on documentation. We don't need to document subjective and objective if it remains
Yeah.
the same from previous exam. We only document that we reviewed that info, correct?
No. Okay. So Judy, let me answer it this way. Okay. Oh, by the way, just to go back to the previous conversation, at the beginning of the year, Medicare posted, and I'm not talking about chiropractic, right? They're in general, they posted the rates. They since updated those rates because just before leaving office, President Trump signed an executive order, but it helped us and it gave us a little boost there. So if you haven't checked, just put in like today's date or January 29th or whatever, and look at the rates and make sure that you're charging the right rates. Okay.
Yeah,
Now, as far as Judy, what you said here, okay, keep in mind, subjective, you're doing like a mini exam. Okay, if you wrote down that you reviewed it and there's no changes, keep it, maybe that's only for an exam, an evaluation, okay? But every day that the patient comes in, no matter what specialty you're in, the patient has to show improvement under your treatment. And so you're always going to kind of like, see what their level of pain is, see what their function is, see how they've improved. The objective findings hopefully are changing. Now, if there are no changes there, but if your medical assistant, as an example, gets some information that day and the doctor documents that they reviewed it, that's okay. But to just do a blanket statement, like nothing's changed, nothing's changed, nothing changed, part of medical necessity is the patient has to improve. So you want to see some subtle changes, over time. All right, depending on your specialty. Okay. All right. So yeah, and so like 99204, that's a high complexity of a case there as an example with your question. So there, I expect to see some changes, especially if you're dealing with, a hot disc or, possible herniated disc or something like that. Okay. So hopefully that makes sense. All right.
And you saw Dr. Mario, do you see the chat under the integrated practice question? It says, in an integrated practice, when a patient presents with 2 or more issues, the nurse practitioner and chiro jointly do a full ortho exam and medical inquiry with x-rays and later meet to discuss case, review x-rays, and create a care plan. Would that always qualify as a level 4?
No, I'm not going to ever say always.
Yeah.
Okay. All right. But okay, so here in an integrated practice, when a patient presents with 2 or more, now I'm assuming that there's a DC, and I don't know if there's an MD, DO, but there's like a nurse practitioner. If the nurse practitioner is conferring with the DC here, and they're discussing the case together here, there, it just depends on the number of problems you're addressing, the amount of tests that were reviewed and analyzed, and the risk. And so again, it's, I don't want to say it's almost like getting into those bullets like we did in 97 guidelines, but it's almost like, okay, the threshold is how much data, the more data that's piled on you, then it's a level 4. So a level 4 is not based on everything you did, it's the complexity as well. Okay. So hopefully that makes sense here. I don't like to give blanket statements here, but again, how many problems? Look back at those tables I gave you. Okay. And those tables are explained even more in my E&M book. And the E&M book is not a chiropractic book, although it is, but it's for anybody to use. But the key is, in the E&M book here, how many different things did you look at? How many, what were your treatment options? What did you order? Who did you talk to? What, information did you review and analyze? You take that into account. Now you can see it's going to be easier for a level 4. I personally don't feel enough chiros, especially, they don't do enough level 4s, and I was guilty of that too. Okay.
Great. Do we have any other questions that have come in? I don't see any others. Would anybody like to unmute themselves and ask a question? All right, I don't guess we have any other questions, Dr.
And as soon as we sign off, they'll think of some.
And
Doc at
they'll
Ask Mario.
Yeah,
Okay.
yeah. Yep, just go to doc@askmario.com or email me and I will forward these questions to Dr. Mario. We're getting a lot of thank yous for a great job, Dr. Mario.
Thank you.
We just love having you on, helping us out. And, I know just from my own personal experience, I use all of these books, the E&M 2021 guidelines. Myself and my coders and my billers, we use these books extensively. They're kind of our yearly Bibles that we buy. And, I wouldn't want to do any billing without it. So, by all means, feel free to get on Dr. Mario and take advantage of the awesome offer that he's made for these discounted books. And we thank everybody for attending today. And thank you again, Dr. Mario. You have a great day and God bless.
Lisa, thank you from my heart. Thank you. I appreciate it.
Okay,
Take care, everybody. Stay safe.
Bye-bye.
Bye-bye. Bye.